Okay, hello. I think it is 5 o'clock, so I'm going to begin our COVID chat. We are trying something new this week and trying to go with a live Facebook streaming of this while I'm still on Zoom. So if we have any technical problems, please forgive us and we will try to reboot, so to speak. But I think we've got everything in place to do it. So shall I go ahead and get started or wait just a minute, Erica? All right, I'm going to go ahead and uh-oh.
Bear with us as we share
Yeah.
the PowerPoint. I think you can just share choose to share the PowerPoint if you'd like.
Okay. Is it up now or not?
It is, but we can see your whole desktop.
Well, I will take care of that. How's that?
You're good.
Okay, so we will start again. So you're seeing it and you're hearing me, is that correct?
Yes.
Okay, I'm going to go. So thank you for joining this afternoon for another chat, an update on the COVID-19 pandemic. Again, my name is Gerry Parker. I'm the Associate Dean for Global One Health, the College of Veterinary Medicine, and the Director of the Pandemic and Biosecurity Policy Program at the Bush School here at Texas A&M. What I thought I would do today, some of you have seen some of this and heard some of this before, but some of it's been updated. I did a presentation, a virtual presentation this week for a preparedness summit. And I talked primarily about the 5 stages of the COVID pandemic. Some of you have heard that, but I'm going to provide a little bit more detail about that. I'm going to put it in context as well in regard to the current situational update, where we stand right now with cases, fatalities, and so forth. But a quick summary too of how we got to where we are. So this is kind of the agenda I will talk about, and I'm going to spend a little bit of time also about the need for pandemic preparedness in the future going forward, and using the H5N1 pandemic preparedness plan that I had the honor to work with back in the G.W. Bush administration at Health and Human Services between 2006 and 2009. So the COVID-19 crisis continues to evolve, and the pandemic is far from over. But again, as a reminder, it started in December 2019, just 6 months ago. It seems like a lot longer than 6 months now. An unusual pneumonia cluster was reported in Wuhan. The Chinese government notified the WHO at the end of December, 31st of December, 23 January, Wuhan was locked down, subsequently Hubei province. That was 60 million people that were locked down toward the mid to into January. February to March, Italian hospitals were overwhelmed. We saw that in shock. Well, the first case reported in the United States, the first death reported in the United States was late February. We watched again in HARS, our New York City. Hospitals were just about almost overwhelmed, exceeding the capacity there, and the tragic deaths that were occurring in New York City. The White House announced and released the 15 days to slow the spread guidelines, mid-March, 16 March to be exact. And state and local governments began and started issuing shelter-in-place orders. A lot has happened in 6 months. And I'm going the wrong way. All right, so here's the current situational update, and I'm using kind of the same format of the slides that I used last time. So let me just kind of introduce the slide. So here's the big picture, the total number of cases. In this case, the global case burden. This is as of 14 June. I haven't had a chance to update these slides since the weekend. It's usually the weekend is the only time I have a chance to update these slides and go through my Excel database and do a current update. And the global deaths are here. So over 8 million cases worldwide and over 436,000 deaths worldwide as of 14 June. And if you look at the this scale is the new daily cases on a day-by-day basis, and this scale on the right is the cumulative scale. So our bar graphs are the number of new cases on a day-to-day basis, and the solid line is the cumulative cases that they have occurred over time. And the same for the deaths, and new daily deaths reported on a daily basis, and the cumulative number of deaths since this began. So if we just look at cases, we are definitely seeing an increase in cases over the last couple of weeks, almost a month worldwide. Interestingly, thankfully, we are seeing a decrease in the reported number of deaths worldwide. But we got to dig in deeper than that and just look at the global. We got to look at country by country in the United States, state by state, and county by county, actually. So in the United States, as of 14 of June, we had over 2.1 million cases, and we had over 117,000 deaths. And so, and actually, we take a look at just the trends here. We do see that overall in the United States, we are seeing a downward trend in the number of cases, maybe a little bit of a plateau here at the end, the last couple weeks, 2 or 3 weeks. And we definitely see overall the downward trend in the number of deaths in the United States. That looks good or better overall, but we're still, I mean, this is still a significant number of people who are dying every day to COVID-19. This has not gone away, but the trend is trending in a good direction overall for the United States. But again, we got to dig deeper into the data. So I'm going to show here New York, and there's a definite downward trend in the number of cases and the number of deaths. But again, even in New York, we're still seeing them. These are impacting people, families. It's tragic that we're losing this loss of life continuing, even in New York, where we're seeing a decided downward trend. But in New York, there's 383,000 cases and over 30,000 deaths. And you'll notice that these scales are going to be much, much bigger in New York than they are for Texas and other states. So back to the US total, and the New York and New Jersey, the whole Northeast was hit the hardest. But if we take out just the cases in New York and New Jersey, subtract that from the US total, what looked like maybe a decline, maybe a plateau in the number of cases in the United States, if we take New York and New Jersey out of that, we're actually seeing a plateau, if not maybe a slight increase rather than decrease in the number of cases in the United States. And we continue though to see a downward trend in deaths, even by taking out New York, New Jersey in that total. So a couple more, three more states to illustrate this. And so California, over 153,000 cases, over 6,000 deaths in California, a definite continued increase in cases in California, and perhaps I would call it a plateau in the new deaths per day in California. Louisiana, our neighbor again, they had a big peak in cases and fatalities associated with the Mardi Gras event, and a steep decline, but we're beginning to see perhaps another uptick in cases in Louisiana. Still, maybe there was an uptick right here in fatalities. We'll see if this becomes a real uptick, and whether this becomes a real uptick 3 to 4 weeks from now. And again, their overall cases, 46,000 and over 3,000 deaths. So their total is still going to be more than Texas. And again, Texas, we're a big state where we see the predominant number of cases up here in the Panhandle, El Paso region, down here in Hidalgo, Cameron County, and definitely the greater Houston area, and the greater Dallas-Fort Worth area, and what I call the I-35 corridor. And I should know my Texas counties better than I do, but the county just north of Travis County, Austin, all the way down to Bexar County constitutes that I-35 corridor. So in Texas, we are definitely seeing an uptick in we are definitely seeing an uptick in the number of cases on a day-by-day basis, and even I've plotted a 5-day moving average as well. But this is a definite uptick in the number of cases, which you've heard about on the news, not only Texas, but in our own county, in our own hometown. So that's over 88,000 cases as of 14 June. It's higher than that today. And over close to 2,000 deaths. It's higher than that today as of 14 June. As far as fatalities, you know, I would call this kind of a plateau that we're seeing rather than a downward trend. We're seeing a plateau in the number of fatalities in Texas. But we're going to unpack this just a little bit more. And so I kind of pulled out some of the data on the greater Houston area, the Dallas-Fort Worth area, the I-35 area, and in our own hometown in Brazos County. And the greater Houston area, I included Harris County, Galveston County, Montgomery County, and one more that I don't remember. But there's a definite uptick in the number of cases in the greater Houston area. And we've heard about that on the news as well. The DFW area, definite uptick in the number of cases, and even that average in the Dallas-Fort Worth area, and a market increase in cases in that I-35 area corridor. And then even here in Brazos County, we have a definite uptick in the number of cases here in Brazos County in just the last 3 days. Yet yesterday there was reported 145 cases. I think today was 70 cases. So we're seeing, and that's not on this graph yet, but it just, there's definitely an uptick in the trend of cases here in Brazos County. Now this is an important slide. This does look at the age demographics and begins to tell us, at least by age, and we've talked about this before, but this is a little bit more data to back that up, about who's at more risk of getting severe disease and actually dying from COVID-19. And also where the predominance of the number of cases are happening, because that tells us probably a little bit about what's happening out and about in the community and where community spread is coming from. So if we look at just the cases, and this is from CDC as of about 10 June, and you can download their data and do some, you know, build your graphs and do some analysis. But as of 10 June, it's quite interesting. If we look at where most of the cases are occurring, they're actually not occurring in the over 65 age group. They're in fact occurring primarily in the infants to the 64 age group. And actually it's really occurring, most of them, this 18 to 44 age group has got the highest numbers of cases in that 18 to 44 age group, followed by the 45 to 64 age group. And then the lowest number of cases here, and then the 0 to 17 age group. That's just the opposite. When we look at fatalities, the most severe outcome of COVID disease. And so it is the over 65 where the predominant number of deaths are occurring. 81% of the deaths in the United States are reported in this over 65 age group. And within that, if we unpack that age group a little bit, it's the over 85 who are really impacted. I don't have the percent, but you can see the absolute numbers here. There's almost 30,000 of deaths occurred in the over 85 group. 75 to 84 age group even is 23,000. Then the 65 to 74 age group, 18,000. But there's still deaths that occur in the younger age groups as well. But down here in the younger age groups, we're not seeing that much in fatalities, but it still happens. Young people can still die to COVID-19. We have to remember that everybody has some risk of dying of COVID-19, the most severe outcome. But predominantly, those that are over 65 are in the highest risk category for severe disease. And again, the tragedy that is unfolded in the United States and elsewhere around the world is our long-term care facilities, our congregate living facilities, particularly nursing homes, assisted living, long-term care for the elderly. And of those states reporting, I think I probably showed this slide last time too, but as of the end of May, over 43% of the deaths are occurring as a share of those state deaths in long-term care facilities. So this has been truly a tragedy that we didn't do more to protect this at-risk vulnerable population, and we need to do better in the future. So bottom line summary, so the at-risk population, age 65 with comorbidities, other underlying health conditions, and even in the younger demographics, those with underlying health conditions are going to be more at risk as well. That means a third of the US population, or close to a third of the US population, actually falls into a high risk category. So it's not just simple, let's separate the older people from the younger people. We live together, and then there are the comorbidities associated with that, and in the younger age demographics and the older age demographics. But we can do more to protect these at-risk populations. And our shelter-in-place policies were so needed. Back when we implemented shelter-in-place policies, but the economic impacts also caused other public health, medical, mental health, in addition to the huge catastrophic impact to our economy. And so we must learn how to live safely and responsibly with the SARS-CoV-2 virus. It's not going to go away. I think that's pretty clear now as we see an uptick in cases even in our communities today here in Texas. It has not gone away. We are still in the early stages of a pandemic, but we don't have a vaccine yet. We don't have a magic cure. So we have to learn how to live with the virus in a safe and responsible way. And I firmly believe we can do that. So I want to go back and maybe give a little bit more information about the 5 stages of a pandemic. This is actually the first time I've put a PowerPoint together to describe what I verbally described before about the 5 stages of the COVID pandemic. And you may remember that I really kind of proposed this back in the April timeframe. And it was really motivated by my experience working in GW Bush administration when we worked on H5N1 pandemic preparedness, and we had clearly stages and phases in our pandemic preparedness back in the day. And that knowledge motivated me to do this, but primarily it motivated me to do something like this because I realized that we hadn't had an opportunity to have a conversation with the American public about what a pandemic means, and that a pandemic could last a long time, that a pandemic actually could affect different communities at different times and different levels of severity, whether that be in our own state, our own country, or across the world. So I think COVID-19 is playing out just like that. It's not going away. It's impacting the world at different times. We're even seeing right now in our southern hemisphere, Brazil, other countries, India, where we may see more tragedies than we saw in Italy and New York City. So this is not going away. And part of this was to give some idea of the phases that we're going to be moving through and how we have to manage this pandemic going forward. And so we've already been through the first 2 phases of containment and broad community mitigation with shelter-in-place orders. And now we've moved into this phase 3, which is containment with targeted community mitigation interventions before we have a vaccine. But there's also going to be, just because we have a vaccine, that doesn't mean everything's over. And then finally, we have to get much more serious about pandemic preparedness in the future. So let me kind of unpack each one of these. So phase 1, containment. I just want to remind everybody that the goal of containment when we started that in late January at the national level was to slow viral spread in the United States. And once here, within our communities, to try to contain it within our communities, to stop or prevent, mitigate, slow the inevitable development of community transmission that we are seeing now. And so none of us believe that we're ever going to stop a respiratory virus once we had the huge outbreak in China. But it was with merit that we did implement international flight restrictions to try to slow the viral spread to the United States. It was very controversial at the time, but the right decision. Public health emergency declaration was declared in the United States. The WHO declared a public health emergency of international concern, ultimately declared a pandemic, but that was more once we got into the phase 2, what I call phase 2. Local, state, and public health were working very hard behind the scene. We did not even realize it primarily to try to contain the virus, begin to build some of the capacities needed for the future. And we had to, those communities and states that took time to prepare their healthcare systems are during this containment phase are better off and better prepared for the next phase. But by mid-March, we definitely reached an inflection point where we can no longer contain community transmission. It just overwhelmed our public health ability to do so. So phase two, broad community mitigation measures. So sometimes I will call this, we took the sledgehammer approach to community mitigation. It was needed at the time because in the sledgehammer approach, government mandated shelter in place orders. So when we started this varied by state, but somewhere between mid-March to mid-April is when states began to implement some of the shelter in place orders. It all varied by state. Nonetheless, what's important, there were a lot of businesses, a lot of schools, a lot of universities began to implement community mitigation measures before there was government mandated for shelter in place. And I think we here at Texas A&M can take a lot of pride, and our leadership began to implement some measures really weeks before there were mandated government mandated shelter in place orders, and that put us in a much better position because we began to take some of these actions early on. And for us, that was pivoting our education mission to online. And we began to stress personal infection control measures, restricting large gatherings in our communities. Schools began to close across the state. Teleworking was emphasized. And again, we pivoted at Texas A&M pretty early on. I think we were ahead of the curve, so to speak, in pivoting to online education to maintain our mission to educate the next generation while also protecting our staff and the community here at Bryan College Station. We had some confusion about what constituted essential business, non-essential business closures. We had simply hadn't talked about it, considered it, like we had back in the 2006, 2009 timeframe. We had a pretty good idea in the list of what constitutes essential critical infrastructure businesses that must be maintained. Those states, again, that took the time to prepare, really had to work on hospital surge capacities. Personal protective supply chains were exhausted. Our diagnostic testing capacity wasn't where it needed to be. So a lot of effort was put in during this phase to build up our hospital capacities, PPE capability, supply chains, and diagnostics. The latter two aren't yet where they need to be, but they're a lot better than they were. And importantly, Congress took action in administration to also provide economic relief. And I think we can anticipate that there may be another economic relief appropriation in the future. So now we have entered phase three, and I originally called this really another phase of containment, but I've rethought what it really means, and it is going back to containment, but it's also going to mean that we're going to have to rely on some targeted, very focused community mitigation measures as well, and all this before we have a vaccine. And what I mean by targeted community mitigation, I mean that in the way that we need to do everything possible, in my opinion, to mitigate having to close our economy again. That had too many unintended consequences that we need to try to avoid that at all costs, if at all possible. But it could be necessary if we don't take our responsibilities seriously. So we're in this phase now to reopen our economy, industry in a safe and responsible way. That started in various places. Here in Texas, it started in May 1st. But various states, it started in May and through June, have begun to reopen their economy and relax some of the shelter in place mandated orders. There was the reopening guidelines that was released by the administration. State and local authorities also had guidelines as well. I think a lot of people will talk about what happened to one of the guidelines from the administration that said we can't reopen, or the guidelines suggestion was we don't reopen until we at least have a 14-day downward trend. I think most states kind of went ahead and began to reopen before we achieved that 14-day downward trend. But I think they looked around and looked at the risk and did some risk mitigation calculations by state, by locality, which is more important, and began to realize one of the key things is we needed to make sure that we maintain hospital capacity to treat those who really get severe disease and save lives as best we can there. So a lot of guidance has been put out, and we here in Brazos County, our local leaders actually made even more stricter guidance than there was at the state level for some of how we began to reopen our business. But how we do this is really going to be dependent on what we're doing to build up our testing capacity, our contact tracing capacity, and triage protocols. And triage, what I mean by there, if you test positive, trying to make sure that we have clear recommendation and guidance about how to voluntarily isolate, or if there's a contact, if you were potentially exposed to somebody that was positive, what are the procedures, what are the recommendations for quarantine for 14 days, and trying to encourage compliance for both isolation and quarantine, and then also to be able to treat those who need treatment. We need to maintain our hospital capacities to care for COVID-19 patients. And this phase will continue until we have a vaccine. And a vaccine, we'll talk more about vaccines next. So phase 4, just because we have a vaccine, and there's a lot of effort that has to happen to get a vaccine, but even after we have a vaccine, we're gonna have to think about what that means and what other control strategies are necessary. Just like we have a seasonal flu vaccine right now. That's not the only answer of trying to mitigate flu every year. Infection control, even some community mitigation measures are necessary for seasonal flu. I think the same thing will be true after we have a COVID vaccine, if we have a COVID vaccine. So this phase, I'm assuming that we will be successful, but that's an assumption. It's not currently known if we will be successful in developing a vaccine, and I'll unpack that a bit more. So I want to just kind of give a summary now, and don't mistake that by I'm not optimistic. I am very optimistic that we will be successful, but there's a lot of challenges yet to make sure that we are. So again, I've said this before, but I am optimistic because we have put a lot of commitment, a lot of resources in doing things in unconventional ways, not unsafe ways, but unconventional ways to develop a vaccine as quick as we possibly can. And in the unconventional manner that we're approaching this is that we are not moving things in series, but we're developing a lot of things in parallel. And we have over 100 vaccine candidates across the world that are in some phase of discovery and development. There are over 10 vaccine candidates now in clinical trials, and phase 2-3 clinical trials are going to be starting as early as January, just about 2 to 3 weeks. And that may mean by the end of the year, we could have some vaccines maybe initially available that would probably mean under emergency use authorization. But I call that a stretch goal, to have any kind of vaccine available by the end of the year. It's a stretch goal. But that doesn't mean that everybody all of a sudden is going to have a vaccine available. There are still many challenges that need to be solved, and we need to be talking about this and working these challenges like right now at particularly the national level, but also at the state level. And so they're going to be issues about vaccine distribution, supply chains, many other challenges. Do we even have enough glass vials to fill the vaccines that are being made? Do we have enough syringes and needles? I don't think we do yet. But some of the detailed issues are going to have to be worked. Big policy questions. Who gets access to the first doses of vaccine? Because we won't have enough for the entire United States population by the end of the year. How do we provide equitable access to vaccines around the world? How do we are we developing vaccines that might be affordable? Big questions. And having access to vaccines to low middle income countries. I know we need to worry about our own population first, but we also have to be thinking about low middle income countries. We live in a big world. This is a pandemic. We got to figure out a way to reduce the disease around the world, because that's going to also help protect us. So we have to be engaged internationally and be thinking about how we're going to solve access to vaccines around the world as well. And then ultimately we'll see, will COVID end up being another seasonal vaccine like flu? I don't know. We don't know yet, but it's something we have to think about. So I'm very optimistic, but I think we have to put some of the realities of timelines and some of the other challenges that we're going to have to be considered, begin to think about that now rather than wait until some of the vaccines are coming off the manufacturing floor. Again, I'm optimistic, but we have to be realistic in our estimates and what challenges yet to be solved. And then finally, pandemic preparedness is absolutely essential. And the goal for this phase 5 preparedness that I also believe we ought to begin right now is we need to elevate pandemic preparedness as a national security priority with sustained resources commensurate to threat, risk, and vulnerabilities. So, domestic preparedness, it's going to take an investment also in international development for global health security. And I believe we have to put, and we can put much more emphasis in that international development, global health security, so we can prevent an outbreak anywhere in the world from becoming an epidemic or a pandemic. And this is where applying One Health strategies to combat emerging infectious diseases at their source. Most of these are going to be zoonotic. And so it's going to be important that we build up the institutional capacities for public health, animal health, and other multidisciplines in low middle income countries to achieve prevention, or to even begin to work on prevention in a meaningful way. Am I optimistic about this? On the one hand, I am already concerned that once this crisis is over, we will go back into a period of complacency and believe that this was a 100-year event, which it is not, and not give pandemic preparedness the attention and resources that it deserves. On the other hand, there is more and more push to think about this as a national security issue, and to begin to think about how do we understand the lessons observed from this COVID pandemic, and to turn those lessons learned into lessons observed into lessons learned for the long term. And there is momentum. I've been talking about it. Others have been talking about it for the need to have a COVID pandemic commission that was on similar, analogous to the 911 commission that that Congress and the administration at the time supported, to understand what happened, why we let our guard down to allow the terrorist attacks of 911, but more importantly, what do we do going forward to take this important, prevent it from happening again? I think we need a similar type commission for the COVID-19 pandemic, so that we really understand in a very thoughtful, objective way, nonpartisan, what happened, what can we do to prevent it? I think you're going to hear more about that in the future. So national strategies, and we do need a national strategy, but I say, and you've heard me say this before, we've done this before, and we've done it with some success. We didn't achieve complete success, but there's the ingredients, there's a roadmap for us to follow. And it was really the roadmap that, that at the time, the President George W. Bush took this as a priority, and Congress took it as a priority as well, and provided a $7 billion emergency supplemental in a non-crisis situation. That was unprecedented. Before an outbreak happened, provided a $7 billion emergency appropriation at the time to begin working on preparedness. And we had a strategy, we had an implementation plan. What was critical about this implementation plan, it had the 300 action items with a lot of clearly spelled out roles and responsibilities at the federal level, the state level, the local level, tribal government, but industry, academia, private, and individuals. And it was discussed, and people understood more about it than we understand about it just before COVID happened. And we also had worked on community mitigation guidance, and we had a conversation with the public about this, and state and local authorities from the federal level, and even understood what kind of risk appetite the public may have, and what kind of appetite the public may have for community mitigation, to include school closures. We never envisioned closing businesses and closing our economy at the time. We recognized the need to balance the economy versus protecting public health and medical. But importantly, we had a conversation with the public, probably not as good as much as we should have, but under the circumstances, it was actually pretty robust, much more robust than we've had today. We just had to respond today. So again, our preparedness objectives at the moment for phase 3 and beyond. This is really the national level objectives. We ought to be saying these at the national level much more often than we are today, but the objectives now are protected at-risk populations. And we need to do that here locally at the state level, but we ought to have more guidance from the federal level too about what that may look like. We need to strengthen our healthcare and public health capacity so we can quickly test, trace, and triage, and we're doing that. We made a lot of progress here at the state level and the local level to do that, but we're not where we need to be yet. We're continuing to build out those capacities. We have to have the capabilities, and we need to better understand how the virus is spreading, the rates of exposure and population immunity. This will take some time, but we're doing it. And it may be necessary. It may be necessary. I know you don't like me to hear, you may not like to hear this, but it may be necessary to implement targeted community mitigation strategies beyond what we're doing right now. I mean, it may be necessary to close schools again. It may be necessary to encourage more telework after we get back more into the workplace than we are today. It may be necessary to restrict large gatherings. I hope not. I hope it will not, but I think we need an honest discussion that these could be necessary in the future. And again, I hope it doesn't happen. But I think how we can avoid that is more communication, because we need to communicate more the importance of individual and infection control responsibilities. We can do a lot if we take on our individual responsibilities to avoid getting sick and avoid making others sick by practicing spatial separation and wearing face masks. Our scientific enterprise is busy developing the therapies and the vaccines, and we are implementing the vaccine development, the warp speed vaccine development program, so that we can deliver a safe and effective COVID-19 vaccine. And again, I'm very encouraged about the vaccine development program. But let me also, I want to offer a word of caution to our policymakers. I think it's important that we are realistic about the timelines. I think it's also very, very important that our policymakers make sure that insist that our clinical trials, there are no shortcuts in our clinical trials, that we must know that these vaccines are work. And I'm going to underscore, we must understand that these vaccines are safe when they're going to be given to a much larger population. So enough said, we just need to make sure that they're going to be safe and effective. There are no shortcuts in the clinical trials, but we can do things in parallel. And again, the strategy right now is to box the so-called SARS-CoV-2 virus in and prevent community mitigation. I'm just going to leave this. I talked about this before, and just want to make sure that there are new people that may have joined us today, that we recently released a book from the Texas A&M University Press. It was led by the Scowcroft Institute. Dr. Christy Blackburn was the editor for this book, but it included topics for business planning, for continuity of operation for businesses in a pandemic, applying One Health principles in the fight against infectious diseases, and lessons learned from the 19 influenza pandemic. But also include the lessons observed and learned in Texas, and what happened in Texas during the 1918 pandemic. And I just learned today, during the 1918 pandemic, there were actually about 50 Aggie students at the time who lost their lives during the 1918 pandemic. So these are real. And I will stop there. And I think we have a little bit difference on our technology today, but we do have a few questions that were sent ahead, and I think there's going to be ability for me to see some things in the chat room. But let me first stop my sharing of this screen, because I might be able to see the chat then. So I think I've done that successfully, and make sure I can see the chat. And we're in. So let me start with the written questions that were submitted ahead of time. And so I want to, the first question is, do we have any updates on the construction workers at TAMU that tested positive? My answer is, unfortunately, I do not have any information on the construction workers that have tested positive. I knew that there were some construction workers that tested positive, but that's really kind of the limit of the information that I have on that cohort that tested positive. The next question, what are the top pre-existing medical conditions to date are the most vulnerable to getting severe case of virus? We're still studying that question, but it's pretty clear that cardiovascular disease, and that covers a lot, whether that be hypertension, coronary artery disease, and other cardiovascular diseases, will make one more prone to severe disease. Endocrine diseases, most notably diabetes and obesity. Was kind of, so what I would call the kind of the top three at the moment that are being recognized in the scientific medical community are cardiovascular, diabetes, and obesity. But there are others. The next one's an interesting question, and does blood type have an impact on severity? And there were some early reports in China that suggested that could be, but just recently there have been other reports that are really kind of almost confirming, or at least validating, that the early reports that were observed in China may have some merit. And so this is going to be something to follow, I think, more closely as we go forward. I would still call these kind of tentative results, but nonetheless, type A has been associated with more severe incidence of COVID-19 disease, whereas type O has had associated with lower incidence of COVID severity. So again, I don't want to overemphasize or overconclude on that, but there are some interesting results that we're seeing more reports of, and that are worth following. So I would call this, this tentatively looks interesting, and there may be something there. And now the next one is a really hard question. So we have been staying at home for quite some time, for months now. It seems longer than months, doesn't it? For those of us over 60 with no underlying conditions, how do we determine when the right time it is to start participating in normal life activities again, i.e. air travel for work, sporting events? This really is a hard question. And at the end of the day, each one of us, particularly those of us who are over 60, I'm in that category, are going to have to really kind of think about that, individually, learn as much information as you possibly can, and see how others fare as well. So I think we're learning a whole lot right now, just in the last 2 weeks, as there've been more people out and about in our community, and we're seeing an uptick in cases. And we're also seeing an uptick in some of the hospitalizations as well. I didn't talk about that as much and emphasize that, but we are seeing an uptick in hospitalization. So we're going to have to really kind of monitor that. Personally, me, I'm starting to do some outdoor activities. In fact, I may go to the pool after this to get some sunshine and a little walk in. But I'm not ready to fly yet, but I may be soon. And so, I'm just sharing my own personal anecdote. I don't have a formal answer for you, but it's a real difficult, hard question that each of us are going to have to come to grips with if we're over 60, and younger age groups as well, particularly if you have a comorbidity. So we're going to learn more about this. We're also, some of the sporting events are starting and so forth, and fortunately, many of the sporting events, at least the participants are in the younger age group. I think, going to sporting events where there's large gatherings, the bottom line, I'm optimistic that we're going to have a football season this fall. How many people can come into the stadium in person, I think is yet to be known. But we will see, we'll learn a lot more over the summer, but one way or another, I think, we need to figure out how to live with the virus, like I've already said, and try to figure out how we can do the things that bring happiness to our life. We need that hope to return to bringing those things that do bring us happiness to our life. So next question. What is the current fatality rate for COVID-19 compared to seasonal flu? Well, actually, I'm not going to go back to sharing your slide, but this is a real good question too. But if you just think about the one slide I showed on the U.S. global burden, and we can put these slides on our One Health website, so you can go take a look at them later. But if you just think about that U.S. burden of COVID, number of cases, over 2 million cases, number of deaths, over 117,000. So we can just take a case fatality rate of what we know. And so if you use a denominator of 2.1 million cases and the numerator of 117,000 deaths, that translates into about a 5% case fatality rate. That's pretty high. In fact, that's real high. However, I still don't think we have a good grasp on what the numerator is. I suspect we have a lot more than 2.1 million cases. That affects the case fatality rate. And so I think Tony Fauci early on in this pandemic used an estimate that he thought at the end of the day, once we know more about the numerator, which is the cases, we'll have a better grip on what the case fatality rate is. But he estimated very early on about 1%. And I kind of jump on that 1% bandwagon myself. At the end of the day, I think it may be 0.5 to 1%, maybe a little bit higher in that range of 0.5 to 1.5%, but that's very high. Seasonal influenza is 0.1%. So we don't know yet. But right now, if you just take that simple numerator and denominator, it's 5%. So next question, at what infection rate of the population will we have herd immunity? Well, most scientists to date, most modelers to date have been saying it's probably going to be in the 60, 70% range. But I just heard today, I was doing an interview with Dr. Peter Hotez, and he just reported that he saw something just today that actually could be kind of game changing and very significant. Again, it was from a modeling study. So remember, there's a lot of assumptions that go into models. And I think a lot of people may be losing some credibility with some of the models. I haven't. I understand the limitations and the positives about models. So, but anyway, he just saw a report from a modeling group that suggested, and a credible modeling group that suggested it may be lower. It may be in the 30 to 40% range. And if it is, that would be really, really good. But time will tell. So bottom line, we don't know, but those are kind of the estimates in the range of estimates. At least it's not in the 95. It's not 95% like measles. But again, we don't know. Time will tell as this is unfold. And then the last question that I got ahead of time was, how do we balance the economic impact of the health concerns? And I think that's what, I think that's what we are doing right now. And I think that's why, I'm still very much in the camp of the strategy that our Governor Abbott, proposed for the Texas reopening, and actually our local elected officials here and our community leaders here in Bryan College Station. I think we are trying to find that right balance between mitigating and learning to live with the virus and as safe as we possibly can in a responsible way, by also mitigating the economic impacts and getting people back to work and finding ways that we can begin to enjoy some of the things that we enjoy doing in our lives. I'm not sure we're going back to the same normal, or even, I'm not even sure I'm going to call it a new normal. I begin to think about whatever the future is going to be. It may be a new dynamic, and we're going to have to learn as we go. But I think we're taking steps right now to try to move forward in a way that is balancing the economic impact with the public health and the medical concerns. So we don't know all the answers yet. One thing I would say, let me take a quick drink of water. I would say one thing about this whole experience with this pandemic. On the one hand, we know a whole lot more about the virus and the disease COVID-19 than we knew just a month ago, maybe 2 weeks ago, 2 months ago. And that's good news. But on the other hand, I continue to be humbled, me personally, and we as a scientific community, humbled by how much we still have to learn. And so we're going to continue to learn as we move forward. And I think we in the scientific policy community need to do a better job of kind of communicating what we know, what we don't know, and making sure that everybody understands that as we learn more, we're going to do a better job of communicating what we learn more. We're not doing a good enough job at that as a scientific community, and definitely some of the policy community to do that. And I think we need to double down on that. So we're trying. But again, I would say that all of us, you and I, as citizens, have a big responsibility here. I go out in the community and I don't see people taking social distancing very seriously. I don't see that many people wearing face coverings. So we just need to take on our individual responsibilities. It is absolutely essential to, I'll keep it, my tagline is cover up, keep your space. So let me see, I think I have some questions in the chat. So here's one question. So do you think the vaccine, once developed, will be optional like the flu vaccine? Vaccines aren't mandatory. Now there may be a requirement for certain groups, like for school children, to receive childhood immunizations, and we're going to have to work through that. But at the end of the day, except for certain groups like school age children and maybe travel vaccines, you know, they are generally optional. I don't think, I'm not envisioning that once we have a COVID vaccine for everybody, which is we're not, that's a long time. I don't think that's going to be solved by the end of the year. I don't think that's an issue we need to worry about at the moment. I think we need to worry about making sure that we have available vaccine for those who want to take the vaccine. I know I'm going to want to take it. And so the biggest thing is access, affordable access to the vaccine on a global scale. We will have to address issues as we began to build up our access and vaccines, some of the issues associated with, say, school age children, recommendations for that. But let me assure you, there are broad-based scientific public health medical advisory boards that do thorough and thoughtful analysis on an annual basis, if not more, that both out of the CDC and HHS and internationally as well, that very thoughtfully consider what are the recommendations for vaccines once we have a vaccine available. And it's not just a whim. It is extremely carefully thought through about any kind of recommendations about the need for vaccines and who should get a vaccine and so forth. So this is not, those decisions are very well thought through about recommendations for who should receive a vaccine. And I assume, for me, my own personal calculation, if a vaccine is available and it's recommended for those over 65, I'm going to line up. So I was wondering what your take is on the claim that contact tracing really only works in Asian or some European countries that have an extensive surveillance. That kind of surveillance we can't legally have here. So there's a lot of good stuff in this question. So let me try to unpack a little bit of it. So one of the things that is, I think, unique in some Asian countries and maybe even in some European countries is some of the technology used and cell phone apps and kind of tracking of people in a way that, in fact, might cross the line here in the United States regarding our privacy concerns. And so I don't think here in the United States we should think about any of those kind of surveillance techniques and so forth that may cross a line of, you know, protecting our privacy and our rights as that we know of as citizens in the United States. On the other hand, there's a lot we can do and must do for contact tracing. That's going to be really our only tool that we have to try to identify and isolate positives in our community. And so contact tracing is tried and true public health practice. Tried and true public health practice. We need to build up the capacities to do the tried and true public health capacities. And that means, so if somebody is positive, you will get or if you test positive, you will get a call from a public health person trying to determine, are you okay? Do you need advice on seeking medical care? Do you need other kind of assistance? How can we help do that? But also try to understand who you may have been in contact with that perhaps was a high risk exposure, and we need to talk to that person, and also provide guidance that may include recommend that they get tested or recommend that they self-quarantine. So contact tracing is going to be absolutely essential, and we've never undertaken it on the scale that we're going to be undertaking it for this COVID-19. And so in the state, even here in our local community, we've established an operations center to assist the county public health in contact tracing missions. It's going to be absolutely essential. We may have to consider some apps to help us with the data management, and we may have to consider some apps to protect our privacy. I'm not saying we're doing it. I think there'll be communities in the United States that will apply some Bluetooth apps that will completely anonymize information, personal information. But it might be nice if you've got a text that said you were exposed to somebody who had COVID-19 and you were in their vicinity for over 15 minutes in less than 6 feet. That might be nice information to know. And you could, that you had that without knowing who it was, where it was. So those apps are going to be explored in certain areas, but that doesn't violate some of the privacy issues that you talked about in the question. What about mutation? Next question. So far, there's not been any reported, I would call it significant mutation in the virus that might change our vaccines that are being developed. So far, and there've been reports about there's been a different, there's a strain in Europe that's more severe than the strain in China. There've been reports of that, but the more serious genetic analysis and scientific reports are not concluding that there hasn't been significant mutations that have an indication or affect severity of the virus and severity of the disease. But we need to keep watching that and keep monitoring that, whether it make it more severe or less severe. So that'd be something our scientific community is constantly monitoring. Now we are, as a scientific community, monitoring the genetic genomics of the virus, and it is constantly changing as it moves from community to community. That's one way we kind of can track how the virus is changing, and we can actually trace how it moved across from China to the United States to Europe. It's how we actually, even in Texas, there's a great publication, excuse me, multi-institutional publication from the Texas Medical Center and other universities that actually through genomic analysis, just in Houston, the virus is coming from all over the world, as you would expect. Houston is such an internationally diverse city. It's wonderful, but also when you do the genomic analysis of the virus that's in Harris County, it's come from China, Europe, South America. So some of those analyses are actually kind of fascinating. All right, another question. We've heard from colleagues that run out of medical commodities like oxygen cylinders, oxygen gas in Brazil. Are we as a nation making a point of stocking up on these supplies now before we get hit in September with a big wave? Brazil, actually, it is kind of tragic to kind of watch what's happening in Brazil right now. I mentioned that earlier. So Brazil is starting to face very severe crisis in Brazil. And so I'm sure that the hospitals in Brazil are actually being faced like we were in the United States with severe shortages of many commodities, to include oxygen, but I'm sure their PPE supplies, being able to protect their frontline healthcare providers ventilators and so forth. I suspect they're really running into challenges like that. Our nation, our states and so forth, we are, and I can't guarantee or promise and overpromise and overstate what we are doing for the fall, but I know that's part of our plans, is to make sure, try to do everything we possibly can to secure some of our supply chains for PPE and others, in case we do have a second wave in the fall. It's not a guarantee that we will have a second wave in the fall. I'm in the camp that I believe we will have a second wave in the fall, or we'll continue to, we might see kind of spikes like we're seeing right now. And we're seeing a spike. I hope that spike goes down, but we may need to see another spike even this summer. I don't know what the fall holds for us, but we must prepare as though we will have a second wave in the fall. And it could be on top of seasonal influenza. So we are taking action as a nation to build up our supply chains to be ready. And next question. Is 15 minutes and less than 6 feet the current standard for being in close contact for someone? That really is kind of the current standard and thinking, but that being 15 minutes, less than 6 feet or close contact, having a conversation with somebody, that is really the standard. And what's important is if you do get a call from somebody at public health and says you've been identified by somebody who tested positive, that person, the interviewer, is going to try to have a conversation with you to try to discern whether it was a high risk contact or not. Because even sometimes, 6 feet, 15 minutes, there may be something else that happened that maybe it wasn't that high, but that interview will be important. And just 1 second. I think we're still on, so I'm going to continue. But it will be really important. But I am hearing from the people who conducting contact tracers that they all, I don't know how often, but sometimes they call somebody that was a contact and the people don't want to talk to them. And I understand that, but I think again, that's where we need to communicate better as community leaders, others, of the importance of contact tracing and why we need to pay attention and answer the phone call and have that conversation if we do get contacted by somebody that's doing contact tracing. It's not to pry, it's not to surveil, it's not to get information about you personally, but it's about to get information to help you make sure that you take the appropriate action so you don't get sick or make others sick. And then any thoughts on the governor stating children will not wear masks when going back to school in August, contrasted with TAM requiring face coverings? Actually, I haven't seen that statement, but let me. I'll just react to it real quick with what I think about the statement. And we have to think about this too. Is children is a big age range, and I think at the end of the day, these are decisions that really need to be made at institutional level, not for the governor to make a broad statement that everybody in Texas is required to wear a mask. Now, I realize some other governors are saying that, and our governor has recommended, actually strongly encourages we do. But it's one thing to make it a government-wide mandate across Texas when we're a huge state. We have some pockets of increasing cases, high caseload. We have some counties that have no cases still. So we have to take that in account. Texas and all of our communities are experiencing the pandemic in different ways. So these are kind of like community level decisions, maybe institutional level decisions and business decisions that we've taken. So we took the position at Texas A&M to try to make our space and our classrooms and our laboratories as safe as we possibly can, that facial coverings should be required, and they are required. They will be required. But each and so I think school districts may have to make those kind of decisions and think about that in each school district. And you also have to remember that some people face masks are medically contraindicated, And for some young people, they're not contraindicated because that could cause other problems. So those have to be considered as well. And that's all the questions that I am seeing. Let me make sure I'm not missing something. That is all the questions I'm seeing. So let me just kind of conclude. I want to thank everybody for taking the time to join in this afternoon. Originally, we were trying to do this at 1:30. I just my calendar is so unpredictable. We thought 5 o'clock probably be best to make it work. We will. Yeah, we would like your feedback if this is continues to be of interest. I enjoy doing it, and we'll commit to continue to do it. And we'll plan to do this again in 2 weeks. Erica will send out the information about it. In fact, what we'll probably do, I may talk about lessons observed but not learned from the anthrax flutter attacks to COVID-19. So with that, I want to encourage everybody. I think you can be ambassadors as you go back into the community and you talk to your friends and colleagues. You can be ambassadors about the importance of social distancing, wearing face coverings when we're out and about in the community. We need to keep our space amongst people, and we need to wear facial covering when we're out in the community. That's really our best tool right now to mitigate disease transmission in our community. So please be ambassadors and carry that message. Thank you very much, and we'll see you in 2 weeks.